It's my pleasure to be here today, and without any further ado, my co-moderator today is Dr. Sharma, Assistant Professor of Medicine. We'll be taking the questions and answers at the end. Our speakers today on this panel are Dr. George Bakris, Professor of Medicine at the University of Chicago and Director of Comprehensive Hypertension Center. We have Dr. Sloand, Senior Medical Affairs Leader of Global Medical Affairs and Cardiovascular Renal Metabolic with AstraZeneca, and Dr. Sen, Associate Professor of Medicine at George Washington University. So I'll turn it over to Dr. Bakris to come on up and start the session.
Well, thank you very much, and good morning. You know, we've been hearing a lot about transplant, dialysis, and what have you. I'm on the other side of the bell, try to prevent all of that stuff from happening in the first place. And so just to give you a background, the clinic that I work in and direct is a referral clinic for people almost exclusively with diabetic kidney disease that have severe, difficult to control blood pressure. And our goal is to delay decline in kidney function, and I was privileged, and you saw this earlier, I was privileged to be on the development and steering committee of the Credence trial, which you saw, which is the first major advance in terms of slowing kidney disease in over 20 years, as you heard. So what does blood pressure play a role in? Before we had the onslaught of diabetes, which really started about 25 years ago with obesity epidemic, hypertension was by far the most common cause of kidney failure, and still is competitive with diabetes, even though it's fallen to number 2. So let me start off and give you a brief review here, because I serve as a guideline writer not only for the American Heart Association, but also for the American Diabetes Association, and also the KDIGO, which is the International Kidney Guideline Committee. So I've interacted with a whole bunch of different people coming at this from a different mindset: heart-focused, kidney-focused, and metabolic-focused. And it's amazing how you can take the same data and come up with slightly different conclusions, which is what happened this year, or 2 years ago when they came out. But I want to give you the history of where these guidelines come from so you appreciate where blood pressure guidelines come from. And they started back here at the NIH with a lady named Mary Lasker, who in the early 70s had a stroke and realized her doctors had no clue how to treat her in terms of blood pressure. So she gave a grant to the NIH for $2 million, whose job it was to put together a group of experts to come up with some guidance for physicians. And so that was the first JNC, came out in 1977. And you can see there, because I'm assuming most of you know about blood pressure goals, you would consider therapy if your diastolic blood pressure was 105. You'd consider therapy. Now people would be in the emergency room. So it's a different mindset, and you can see the evolution through the different JNCs all the way to the current one, as to things have all steadily moved downward, and there's been modifications. Diastolic blood pressure is important in terms of predicting mortality if you're under age 50. And I don't have time to get into that with you, but there's a seminal paper published in 1997 in Circulation that shows that. If you're over 50, it's the systolic blood pressure that's the determinant. There were no guidelines for systolic hypertension until the JNC3, and that's because there were really no good trial data. So this is an evidence-based kind of approach, and as more evidence has come to the front, less opinion is there and more evidence is there. So that gives you the history. As you can see here, hypertension is still number 2 as a cause for going to kidney failure and dialysis. Now, the one thing that's new in these guidelines, although the other guidelines talked about it, it's front and center in this guideline, it's front and center in the European guidelines, and that is, let's move away from the numbers a little bit and let's focus on what your risk is, because the higher your risk is, the more benefit you're going to get from a lower pressure. And so basically what they've done is the epidemiologists really did a stellar job of going through, looking at clinical data, and while the data uniformly supports a 15% 10-year risk for cardiovascular events, the data there is overwhelming, they wanted to instill kind of a CERTS approach to guidelines. Remember CERTS, the breath mint, 2 mints in 1? I'm old too. So it turns out that they said, look, let's not ignore the young people. So if you're at 10% 10-year risk, then you should be in the same boat and everybody should be treated. And so where should you be treated to? Well, they came up with less than 130, and I won't get through all the data for you because that's a whole separate talk. But the data for that was pretty solid, especially if you have a history of coronary disease, diabetes, advanced kidney disease, overwhelming data supporting this. So it was kind of easy to come up with that. And of course, in approaching this, what happens with many physicians, because again, they're not paid for this, although they all know it, no one sits down and educates the patients about low-salt diets, exercise, and those kinds of things. A, because they have an attitude that the patients won't listen, and B, they're not getting paid for it, it's extra time, and there's somebody with a gun in their head that wants you to crank patients out. Now, how do I know this? Because I'm number 4, doc number 4, that ultimately they end up on my doorstep. So they've already seen the cardiologist, they've already seen the general internist, and in many cases they've seen the nephrologist. I ask them what they know about sodium intake. Don't use any. Okay. Any specifics? No. So it takes time to do this. And as I tell them, properly done, that's worth 1 drug easily, and in some cases 2 drugs. So it's very important to do that. Smoking, I'm not going to waste your time. Obviously, if you're, a little plump, you should probably work to try to become less plump, especially if you have a family history of diabetes, because you're going to be in big trouble. And so the modifiable risk factors are really harped on that really need to be educated on the patient side. There is a calculator that was devised, the ASCVD risk calculator, and this calculator is a freebie. You can download it. It's not perfect, but it is validated, and it gives you, as long as you're kind of between 40 and 79, a very good idea of your risk. And all you got to know is your age, sex, cholesterol values, whether you have diabetes or not, whether you have hypertension or not, and then what's your race. And you put that into the equation, and you get what your 10-year cardiovascular risk is going to be. And then actually, if you plug in that you fixed the things that are problems, it then tells you what your new risk is. And this is very powerful to show the patient, because if there's any question about taking meds, remember, everybody talks about hypertension as a silent killer. Let me remind you, kidney disease is a silent killer. And that's the problem, because most patients, and we just presented this data at the Kidney Foundation meetings in Boston a couple of weeks ago, 60% of people with stage 3 CKD have no clue that they have CKD. That's a big problem. So I'm a big fan of having the patient be their own advocate, but how can they be if they're not educated? And it's up to the doctor to educate them. So the other thing that's big in the guidelines is blood pressure measurement. People come in, they're in a hurry, the nurse, you got your coat like this, they'll put the cuff around here, they'll check the blood pressure, and off you go. Yeah, that is about a -10 in terms of grades, because that is not what you're supposed to do. And there are specific guidelines on how to measure pressure. Those are really harped on big time. Again, not practical, because they take extra time to do properly. And the good news is, if you do them properly, you will avoid indiscriminately giving medication to people that have white coat hypertension, that is high pressures in the office that are normal outside, and you'll avoid side effects. So there's a lot of reasons to do this correctly. It's not just academic, but again, timing is an issue. Out-of-office blood pressures. The patients are instructed to take charge of their own disease. So go home, get a blood pressure cuff. They should be educated as to how to measure their blood pressure at home and when to measure it at home, and give data to the physician. I do this routinely, and what I've realized is I don't need to worry about adherence, because the patients that are sending me all the data do amazingly well. The ones that don't send me data, I already know they're not taking their meds or they're not following the diet. It's a no-brainer. And I've actually confronted them, and they've admitted it. So it's cheap adherence measures. Now, white coat hypertension and mass hypertension are very important, and I just want to quickly mention this. White coat you know about. A lot of people think, it's not a big deal, I'm just nervous. It kind of is a big deal. And I'll show you some data in a minute. Mass hypertension, even more nefarious, because you have a normal blood pressure in the office, but you're in a high-stress job. You're an engineer, you're working on the board of trade, you're doing something that's heavily analytical, time-pressured, intense, and your pressure can go up. And you would never know it unless you had some kind of misfortune of having a stroke or having a nosebleed or something like that. Now, this is data taken from a registry in Spain of about 60,000 patients. And they looked at cardiovascular mortality and all-cause mortality. I'm showing you all-cause mortality for white coat hypertension is 2.2-fold higher than someone who's normotensive. And if you have masked hypertension, it's almost 3-fold higher. And look at this, if you have sustained hypertension, white coat hypertension, sustained hypertension, not a difference. Very important. Now that's for all-cause mortality, and if you look at cardiovascular mortality, trends are very similar. So it is important to measure home blood pressure, and it is important that if you're in a high-stress job, to make the physician aware that you're in a high-stress job and you think your pressure may be elevated, because you yourself can actually check your pressure at work just to see if it in fact is elevated. And I can give you anecdotes about that later. This was put in the guidelines that I think is critically important, and I recommend it to all nurse practitioners and PAs and everybody. Xerox this and give it to all the patients, because it tells you not just what the recommendation is, but gives you specifics and tells you how much blood pressure reduction you're going to get if you actually follow these things. And this is where I get the thing that it's worth 1 blood pressure medicine, because in some cases, if you do all this and do it well, it could be 2 blood pressure medicines. Now, how can you look at all the same data and come up with different conclusions? Well, a lot of this has to do with patient perception as well, or what physicians think the patient perception is. So in the US, we don't care. You will do it this way, and I'm sorry, it's for your own good. So shut up and just do it. Less than 130/80. But I don't feel good at 130/. I'm sorry, it's too bad, gotta do it. In Europe, they're like, listen, less than 140/90, we have 60 years worth of data that says this is good. And how much better is less than 130/80? Well, if you're very high risk, diabetes, advanced kidney disease, both, advanced heart disease, yeah, it is better. But forget about that. We're not talking about that. We're talking about Mr. Jones, who doesn't have kidney disease, doesn't have heart disease, has his cholesterol controlled, is doing fine, is exercising, is watching his salt, and his pressure's 134/82. Are you going to call him hypertensive? Well, the Europeans, the Latin Americans, the Asians would all say no. So it's very important to understand where this is coming from. You cannot force feed a preventive strategy and a treatment strategy for people with advanced disease and put them in the same document and say it's good for everybody, because there are real issues with that. So I just want you to understand that there is not equipoise in terms of the numbers, and there are good debates, and in fact, I debated the chair of the guideline committee and won by a narrow margin, even though in their hearts, these were cardiologists that really, for them, they want you at 120, but it's a mindset. So you really have to look at the data to be careful. Now, a couple of other things. We have been saying in the guidelines since 1996 that you should be starting with 1 pill, 2 drugs in people that have 20/10 blood pressures above their goal, and the goal was 140/90. It has never caught on because hospitals don't use combinations, and the funding agencies and CMS say, well, that's just a convenience, forget it. And so we're not going to do that. Get the individual pills and just take it. So patients, you've already heard, are taking 12 to 16 medicines with advanced kidney disease. I can tell you that they very much appreciate taking fewer numbers of pills. Very important. And there's great arguments for that. And again, this was in JNC 7, it was in JNC 8, and now it's in the ACC/AHA guidelines. The Europeans start with combo therapy. They don't care what's going on. You need to be treated, you get 2 pills. Why? Because they figure you're not going to take anything, so if I just give you 1 pill with 2 meds at low doses, you're going to be in better shape. And they actually have very good data to support that. So I think it's important to know there's a difference in the approach based on data of adherence in different populations to get to the goal. And even there, where it's less than 140/90, they're still advocating single pill, low dose combination. Now, kidney disease, very specific finally, because in the day, everybody was putting ACEs and ARBs in the drinking water. There's zero data to support that that does anything beneficial in terms of very early stages of kidney disease. However, the data is overwhelming. If you have 300 milligrams or more of albumin, control of blood pressure to levels of less than 130 clearly has benefits not only on the kidney, but to cardiovascular disease. If you go below 130, there's no further benefit to the kidney, but there's benefit on reducing cardiovascular events. These are 3 randomized trials that basically showed no benefit of lower blood pressure on slowing progression of kidney disease. None of these people had diabetes. These are all people that had non-diabetic kidney disease, hypertension, IgA nephropathy, etc. All of them showed cardiovascular benefit. SPRINT was not powered for a renal outcome, which was the most recent one. But again, like the others, it showed benefit on slowing progression of kidney disease. And if you got below 130, there was a cardiovascular benefit as well. So very important point. The ADA has basically said that the ADA and the ACC, for the first time in history, have agreed to accept each other's guidelines. And the ADA basically says less than 130/80 for almost everybody, but there's a subgroup that can't tolerate that or has some other reasons not to be there, and so less than 140 is the goal. So I think, again, an important point to keep in mind, and this is very strong evidence, and if you have diabetes and if you have a proteinuria of greater than 300, you have to be on an ACE or an ARB. If you just have diabetes and no kidney disease, nobody says you have to be on an ACE or an ARB. If you want to use one, fine, but there's no mandate that you have to be on it. Now, I just want to make a point quickly about blood pressure levels and differences between those with diabetes and those without. This was a study, epidemiologic study of 19,000 people, looking at people with diabetes and looking at people without diabetes. And you can see here that the arrow is pointing to about 130. And so there you go. If you get down to 130, you're fine. But then what happens, and that's the hazard ratio for mortality on the y-axis. What happens when you get below 120? It goes up pretty high, pretty quickly. If you look at those without diabetes, there's no problem at all. You can go down to 110, life is good. Now, there's a number of speculations as to why this is true, but I think it's important to know, and I can show you 4 other studies show the same thing. So one size does not fit all, and you do need to understand your disease process. This is for people that are older, shall we say, vintage. So 65 to 79 and then over 80. And you'll notice that in most of those boxes, there's the little term, if tolerated, if tolerated. So you're working with the patient to get their pressures down to 130. Many people with very stiff vessels that are old will not tolerate it. And so there's no reason to push. And there's no evidence that you get a benefit in that subgroup. So very important point. This is just to let you know that if you overtreat, you've got people at very low risk, the benefit is actually going to not be very good and the side effects are going to be higher. So you need to select people at very high risk that you're going to treat, and those people should be aggressive. The people at very low risk, you don't need to be that aggressive, and less than 140 is fine, and this is one of 4 reports that came out looking at this. So just to finish, there's no strong data supporting less than 130/80 to slow CKD progression. So if you're focused on the kidney, then unless you have a gram of proteinuria, unless it was really advanced kidney disease, there's some soft data supporting that. But otherwise, it's cardiovascular benefit that you're getting. For cardiovascular risk, definitely less than 130/80. And then if you look at the major guideline, less than 130/80 is what's recommended in people with diabetes and in people with kidney disease. Everybody else, you really have a hard time going to that level for the just small additional benefit that you're going to get. And lastly, you should not put ACEs and ARBs in the drinking water because they really have only been shown to be a benefit, at least for the kidney, if you have either heart failure or if you have greater than 300 milligrams of albuminuria. Thank you very much.
Good morning, good afternoon, good evening, wherever folks are in the world. I'll start out by saying in 2012, I don't know if Eliza Thompson's still here or not, but she made a comment, but 2012, KEY, Kidney Health Initiative, started because there was lack of any substantive change meaningful to patients, improving the patient-centered care for decades. And I think the fact that we're meeting here today really highlights the fact that there are really some really exciting things going on in the world of kidney disease and innovations that can actually improve patient-centered care. And I'll salute the Kidney Health Initiative, AAKP, and George Washington University for their foresight, their initiative in putting this together and providing all of us a lens to actually view what's been in the pike and what's coming and what's already here. So I think, again, very exciting times. I've been asked to talk today about innovations in the treatment of CKD-related anemia and to focus on patient-centered outcomes. And I noticed that Brian has actually stepped out of the room. I think Michael may be still here. Again, focusing on patients again. So what I'm going to kind of try to concentrate on here are the past, the present, and the future as far as where we are with anemia of CKD. And I'm going to start out with a historical perspective as far as the anemia of chronic kidney disease. I wondered if this was going to be a slide that was used over and over again today and yesterday, but I didn't see much of it. But I think most of you know CKD happens in about 10 to 12 to 14% of the world's population, which means, and again, Paul, you were talking about AAKP now having a global reach, about 500 million people in the world have chronic kidney disease. In the United States, we have the same picture. Again, here the percentages go up to about 14% of the population, and I think that may be due to the fact that we're better at detecting than other areas of the world as far as chronic kidney disease. But in the U.S., it affects about 30 million patients, and you can see from this slide that as we get older, you're more likely to develop chronic kidney disease. If you're a man, you're more likely to, if you're a woman, you're more likely to get it as well. And there are a number of comorbidities that are associated with chronic kidney disease. One of those comorbidities is anemia, the anemia of chronic kidney disease. And what this slide shows you is that the further progressed your chronic kidney disease as far as stage of CKD, the greater the likelihood you are to have anemia associated with that chronic kidney disease. So at stage 3, about 17% of the patient population has it. When you come to stage 4 and stage 5, we're talking closer to 50% of the population has anemia. Why is this important to patients? And again, Brian's left the room, but he mentioned something yesterday as when he's sitting in the dialysis chair and your blood's sitting outside, half your blood's sitting outside in the device, and how cold the dialysis unit is. And I know having a dad and an aunt, both who had chronic kidney disease, both developed it after I decided to be a nephrologist, they complained about the same types of issues. But if you look at the studies, you see that with regard to patients, some of the things that are most prominent and are most important to patients is fatigue. And while there are a lot of things that can cause fatigue in chronic kidney disease, it's hard to sort it out. You know, itching, twitching, retching, everything that goes on in chronic kidney disease. You know, what's causing fatigue? Is it under dialysis? Is it inadequate dialysis? Is it the recovery syndrome after their dialysis? Or is it anemia? Or is it all of the above? Again, anemia does play some role. And again, this is a study that looked at the association between quality of life and burden of kidney disease, and you can clearly see that there's an association. And again, I don't want to say that correcting anemia is going to fix all this, but there are some studies that show that correcting the anemia does improve quality of life. I'm thinking some systemic reviews that just published in the past month or so, and also improve health resource utilization as well, and I'll come to that in a minute. The other thing that anemia is associated with is an increased likelihood of cardiovascular hospitalization, an increase in progression of chronic kidney disease, and an increased likelihood of death. And again, likewise, I can't say that if you fix anemia that all this is going to get better, but there again, there are recent studies that show that, again, quality of life and health resource utilization, driving hemoglobins up to close to 12, actually do improve some of these parameters. So why does, stepping back to physiology, why does why does anemia of CKD occur? It's been recognized. This is a very, very old slide from Misra and Kerr, showing that as your kidney function deteriorates, your hemoglobin hematocrit progressively decreases as well. And we now know, thanks to the work of a lot of investigators, that this is due to a progressive decrease in erythropoietin produced by the peritubular cells within the kidney, the fibroblasts within the kidney. Thanks to work of a number of investigators over decades, erythropoietin was eventually developed, recombinant human erythropoietin was developed. It was demonstrated to improve the anemia of chronic kidney disease in some early studies, and it was eventually approved by regulators in about 1989, 1990. And I'll say I was one of the early investigators that actually did some studies looking at iothalamate clearances, demonstrating that there was no deterioration in kidney function in patients with chronic kidney disease using erythropoietin. But with the approval of the drug, with administration of the drug, us nephrologists, and again, I'll say as a nephrologist, even back in the 80s, I was treating patients with decadorablin, a male hormone, to improve patients' hematocrit, hemoglobin. And I remember calling patients, women, on the phone and asking if they were home, and the response, is Anna home? Yeah, this is Anna. Would frequently be the response. So when this drug actually became available, I put any number of patients on it, really felt very good about treating patients, and they felt good about their quality of life that resulted. I had patients even telling me, Jim, I can tell that my hemoglobin level has dropped below 13 because I'm less bouncy. That patient actually is still around. We had exchanged some emails within the past couple of months. She's still up in Rochester, New York. Anyway, but there was progressive, you can see from this progressive use of erythropoietin along with that data, and a progressive increase in hemoglobin hematocrit. Then along came trials, and I'll also say that I was invited to be part of the choir trial, and I refused because I thought it was unethical not to treat patients. But lo and behold, what these studies showed, and there were studies in hemodialysis patients, and in non-dialysis patients, the choir, create, and treat were all in non-dialysis patients. But what they all demonstrated that there was an increased risk of major adverse cardiac events that was associated with driving hemoglobins higher with erythropoietin. And while initially, as I say, the thought was, hemoglobins being higher is a bad thing, subsequent post hoc analysis, and this is analysis of the choir study, and I'm going to ask you to look at it and glaze over. You've been sitting there for a while. But what this looks at in the choir trial was tertiles of hemoglobin, that's across the x-axis, and across the z-axis, if you will, as tertiles of erythropoietin. And what you can see here is that lowest to highest level of hemoglobin, that's that first row, doesn't really increase your risk of cardiovascular disease very much at all. Conversely, if you look at the z-axis going backward, the higher the dose of erythropoietin that one is using, the higher the cardiovascular risk. And you can see that the highest risk is in patients over in the left-hand corner in the back, and those are patients that are on the highest doses of erythropoietin and had the lowest levels of hemoglobin. So this suggests that it's not necessarily the high hemoglobins that are driving cardiovascular adverse events, but it may be the high doses of erythropoietin and what they do, whether it's vasoconstriction, and again, we know that that causes hypertension as well. So what happened as a result? Well, irrespective of those post hoc analyses, there were significant changes in international and national guidelines. And you can see here KDIGO guidelines as well as the KDOQI guidelines suggesting that now patients not initiate treatment for anemia of chronic kidney disease, not at 11, but at 10 or 9, with the goal of treating either to 11 or 12. Does not give people a lot of leeway, does not give us clinicians a lot of leeway as far as treating patients. And I'll also say, from the patient's perspective, it doesn't allow them to actually have a hemoglobin restored to what we'd consider to be a normal level that would allow us to function in a normal fashion. So if one looks at what happened to a use of erythropoietin, what happened to the hemoglobin profile, there was a progressive increase until about 2006, 2007, at which point the results of the TREAT study came out, FDA black box guidance came out in 2011, KDIGO guidelines came out in 2012, and you can see there was a progressive decrease in hemoglobin levels, a progressive decrease in use of erythropoietin for fear of what would happen and what we'd be doing to our patients. So what's the current landscape now? So we just talked about the past. Where are we now? So if we look at what happens to patients not on dialysis, it's only about 23%, and this is predominantly non-dialysis related CKD. Only about 23% of those patients are treated with any form of therapy for their anemia, for their CKD-related anemia. So it could be iron, could be erythropoietin, could be folate, could be B12, but it's a very low number. 77% aren't receiving anything. And this was rather shocking to me. I just pulled this out of USRDS last year, so it reflects data from 2 years ago, 2016. Patients starting dialysis, so this is, again, from the 2728 form, people starting dialysis have a hemoglobin of 9.3, and only 13% of those patients are on erythropoietin, yet we become very schizophrenic. Within 90 days, 80% of patients are on erythropoietic agents, and we're driving hemoglobins to 10.8. So again, maybe it's just that our feet are being held to the fire with regard to CQI, but again, to me, this really demonstrates schizophrenic behavior, and again, that we are drastically under-treating patients. One of the other challenging issues that we see with regard to chronic kidney disease, particularly in the end-stage renal disease populations being treated, is something called erythropoietin resistance. And you can see here that despite best efforts, about 20% of patients don't even reach a hemoglobin greater than 10. And again, we term that ESA resistance. Why does this happen? If we look at patients with chronic kidney disease, as GFR progressively decreases, what one sees is there's a progressive increase in inflammation. NADPH oxidase is one of the things that we see gets fired up as you lose kidney function. Other things may be playing a role as to why inflammation is occurring in these patients as well. But you can see all the biomarkers suggestive of acute and chronic inflammation really are firing off and increasing as kidney function is progressively lost. What impact does this have? So if we're trying to make red cells, not only do you not have enough erythropoietin around, but if all we need to do is start from the left side of the slide and start moving our way over, number one, inflammation decreases erythropoietin production. Number two, it decreases its impact on the bone marrow. Number three, it decreases the red cell survival. And then number four, and maybe most importantly, is that inflammation increases the production of a protein within the liver called hepcidin. And hepcidin was just coming out about 2007 when I decided to go into industry and do more dialysis-related stuff, and I find myself back in the same arena now, fascinated by the same issues that I was introduced to back in 2006, 2007. Hepcidin is thought to be more or less the master regulator of iron metabolism in the body. So if there's increased inflammation, hepcidin increases, and what hepcidin does is it inhibits gastrointestinal absorption. So if people are taking exogenous iron, even if they're just taking whatever iron's in their diet, the hepcidin will block the entry of iron into the bloodstream. It also inhibits or causes involution of a iron transporter called ferroportin. And then thirdly, no matter what our body stores are within the reticular endothelial system or within macrophages, hepcidin inhibits the ability of the body to cause egress or draw upon those total body stores of iron. So hepcidin, again, is a major issue. And if we return back to this specific population on dialysis that we term EPO-resistant, you can see here, I have in bold here, not only are these patients receiving extremely high doses, the highest doses of erythropoietin, in order to achieve, or barely, not even achieve, a hemoglobin of 10, but you can see they're characterized by having, as we talked about, very high levels of CRP, C-reactive protein, hepcidin because of all the inflammation that's going on, ferritin, which is a marker of iron, but it's also an acute phase reactant, PTH, and again, the nephrologists around the room and the patients around the room know that elevated PTH means osteitis fibrosis cystica, which is inflammation within the bone due to secondary hyperparathyroidism. And of course, since their iron is not getting out of their bodies, not getting out of the deeper stores, they're requiring higher doses of IV iron in order just to make whatever red cells they can despite the resistance. And the most important thing here is these individuals are at highest risk of cardiovascular death. And I'll allude back again to this slide, looking at tertiles of hemoglobin and tertiles of erythropoietin. Looking at that back left corner, the highest levels of erythropoietin are those are the individuals that have the highest risk of death. So just to review very quickly, what I've just talked about, CKD is a serious disease associated with morbidity, mortality. Exogenous replacement therapies really are incomplete solution for erythropoiesis, and they have serious cardiovascular risk associated with them. Certainly, they made a huge difference as far as reducing allosensitization due to red blood cell transfusions, reduced hepatitis B, hepatitis C, HIV, and again, hopefully we're still looking at Zika virus now when we're considering transfusion. But we know now that they're also associated with increased cardiovascular risk, and given the other problems with regard to hepcidin, ongoing inflammation, they really don't address that issue of inflammation and immobilization of iron, or absorption of iron much less. And then lastly, CKD anemia, as I alluded to, is more than just erythropoietin and iron deficiency. Contributing causes include that ongoing inflammation and increased hepcidin levels that impair GI absorption and mobilization from existing stores. So I think it calls for a time to rethink about anemia of chronic kidney disease. So it brings us to the last piece here, the last section of the talk, and that's discovery and innovation, and something called the HIF pathway, which is hypoxia-inducible factor. So yesterday, Dr. Appel talked briefly about trypanosoma cruzi. We are all familiar with sickle cell disease and malaria, but what I'm alluding to is that natural selection favors mutations in genes that perpetuate the species. And with regard to malaria, sickle cell developed, it perpetuated itself because it had a selection advantage in keeping people alive from malaria until they could reproduce. Unfortunately, the side effect was sickle cell disease if you happen to have both genes. Likewise, trypanosoma cruzi, if you had both the G1 and the G2 allele, it protected you from trypanosoma cruzi, but it's also got some negative effects. Here we're looking at an organism, us, right, or any other organism. There's a protective advantage in being able to adequately adapt to changes in oxygen levels. So whether we're sick, whether we have respiratory disease, whether we develop a pneumonia, or if we ascend to high altitude and we live at high altitude, there's a selective advantage to us if we can accommodate, if our bodies can accommodate to low oxygen levels. And that's exactly what happens. So when we're exposed to low oxygen, or if we take a trip to Denver, or my favorite, going to Breckenridge, Colorado, and you experience low oxygen levels, what happens is your kidneys sense a low oxygen level and they jack up the erythropoietin levels. And likewise, your bone marrow, your reticuloendothelial system starts to relinquish extra iron. The macrophages relinquish extra iron. and the gastrointestinal tract enhances iron absorption from the duodenum. And all of this conspires, like we're in DC, this colludes, I'm sorry, to make more red blood cells in the bone marrow. Okay, so you have more red blood, more erythropoietin arriving there, more iron that's arriving there, and you should make more red blood cells, improve the amount of oxygen that's delivered to all your tissues. So what do we know now? So what was developed back in the 70s and 80s, and then was just replacement therapy, where we gave people what appeared to be their deficiency, erythropoietin. We know much more now about the physiology and the pathophysiology of anemia of chronic kidney disease. And we know about this dimer called hypoxia-inducible factor. Hypoxia-inducible factor is composed of two components, an alpha component and a beta component. The beta component is constitutively produced, so it's always hanging around. It's always there, but it doesn't do anything unless it's coupled with the alpha component. And the alpha component is oxygen sensitive. There's an enzyme that's floating around in the cell called prolyl hydroxylase, and what it does is it takes oxygen if it's around, and it deposits it, or it hydroxylates the alpha component of hypoxia-inducible factor, and it essentially tags the alpha component for destruction, degradation, ubiquitinization, okay, and destroys it. So if you're in a normoxic situation, as most of us are here, for the most part, that's being destroyed, and there's no need for you to have additional erythropoietin generated. On the other hand, if the oxygen levels drop for any reason, we ascend to Denver, Colorado, we ascend to Breckenridge, we take a trip to Mount Everest, what happens with the low oxygen levels is, since oxygen is no longer around, I think this is animated here, by the way, but just haven't been animating it. When oxygen is not around, prolyl hydroxylase is inactive, and the HIF-alpha subunit does not get destroyed. It combines with, it enters into the nucleus, it combines with the constitutive component, the beta subunit, and it results in transcription of any number of proteins, including erythropoietin, erythropoietin receptor, transferrin, transferrin receptor, and it has an indirect effect on hepcidin. I'm going to come to that here in a minute, I think. So again, this is a cartoon that illustrates everything that's stimulated, and I just talked about already. So we looked at the right side of the screen, stimulates erythropoietin production, EPO receptor production, transferrin receptor, transferrin. Oh, I did mention before, it also activates the enzymes in the gastrointestinal tract to improve iron absorption. So the divalent metotransferase is enhanced. That increases the amount of iron that's absorbed by the gastrointestinal cells. Duodenal cytochrome B, which converts a 3+ iron into a 2+ iron, which is the only iron that you can actually transport across the gastrointestinal tract. And again, as I pointed out, the very important decrease in hepcidin that's probably driven by something called erythroferrone that comes out of the bone marrow. So, as you might suspect, given the increased knowledge of the physiology, pathophysiology of anemia of chronic kidney disease, over the past several decades, the goal from investigators has been, how can this be harnessed to better treat, more efficiently treat, more effectively treat the anemia of chronic kidney disease? And what's happened is the development of these agents called prolyl hydroxylase inhibitors. And what these agents do is they essentially replicate or reproduce in the cell a sense of hypoxia. I'll also add in here, I took out the slides, but one of the things we also discovered over the past several years, we've all assumed it's the peritubular fibroblasts that are gone, they're just totally destroyed. Actually, what happens within the kidney is there's a pseudo-normoxic situation that exists. As you lose nephrons, there's less sodium that's being filtered, less sodium to be reabsorbed, and it's the reabsorption of the sodium that actually consumes oxygen. So if you're not consuming oxygen, the kidney, the medulla, and the cortex both sense that there's a normal amount of oxygen present, and there's the stimulus for erythropoietin isn't even there. So what these drugs do, prolyl hydroxylase inhibitors, is they inhibit prolyl hydroxylase. They prevent the alpha subunit from getting hydroxylated. It can then combine with its beta subunit and then trigger all those substances necessary for complete erythropoiesis that we just talked about. There are 4 of these agents that are listed on this particular slide. I'll also include that there are several other agents that have now become available or in stage 1 and stage 2. Some of them beginning phase 3 trials throughout the world. They have different half-lives, different dosing frequencies, and different qualities. But I'll highlight again the fact that these agents can decrease hepcidin really has a prominent effect on allowing for a much more coordinated erythropoiesis. So with hepcidin being elevated, again, I have here a little cartoon, ferroportin is decreased in the gastrointestinal tract. It's decreased in the that's the spleen within the reticuloendothelial system and within the liver. And you can see because ferroportin is caused to involute by the presence of these high levels of hepcidin, there's very little iron. It's just coming out of the little spigot there by drops, where you're not really getting a completed erythropoiesis. If you can decrease that, and that's what happens with these HIF-prolyl hydroxylase inhibitors, one now actually opens up the spigot on all the iron that's now available. So one can now increase plasma iron and have a complete erythropoiesis. So the total erythropoietic effect that one can see is an upregulation of the dimethyltransferase, the cytochrome B, so you get increased absorption of gastrointestinal iron. There's an upregulation of ferritin and transferrin receptor, increasing the amount of iron that's actually delivered to the bone marrow. And there's an indirect inhibition of hepcidin, increasing ferroportin and reticuloendothelial system iron release, and upregulated endogenous EPO and EPO receptors. And of course, these agents also promote RBC maturation. And I think one of the things that's most important about these agents is that the level of erythropoietin, endogenous erythropoietin, that they generate is much lower than occurs when one is giving exogenous erythropoietin. You can see the levels here are in the 500 range when one gives exogenous erythropoietin. And again, this is to achieve the same level of hemoglobin, right? Yet one has normal or slightly elevated levels. I mean, something that would be comparable to what you'd see if you did go to the mountains when one gives a hypoxia-inducible factor prolyl hydroxylase inhibitor. So in summary, again, I don't know how much time I've taken here. It feels like it's gone by quickly. But in summary, anemia is common. It's an anticipated consequence of CKD. It's an independent risk factor for morbidity, mortality, and cardiovascular events. Systemic reviews demonstrate that untreated CKD anemia is associated with reduced quality of life and increased health resource utilization. Secondly, ESAs, erythropoietin stimulating agents, were a medical breakthrough, and I don't want to take anything away from that because my dad appreciated them. I was dosing him with EPO, and it really improved his quality of life, as it did for any number of my other patients. But it really is an incomplete solution, and it does have serious cardiovascular risk associated with it. Advances in our understanding of the physiology and the pathophysiology of chronic kidney disease-related anemia really have occurred in the past couple of decades. specifically around the central role of hypoxia-inducible factor, providing a coordinated erythropoietic response, and the development of these HIF-prolyl hydroxylase inhibitors, many in or completed in phase 3 trials, really do offer a potential to improve patient-centered outcomes in CKD. And with that, I say thank you.
Good afternoon. It is clearly in the afternoon now. Thank you for giving me the opportunity. I'm an endocrinologist at GW University, and thanks to AAKP organization and its organizers, Dr. Raj, for giving me this opportunity to discuss about stem cell therapy in diabetic kidney disease. So I don't need to reiterate this again, but chronic kidney disease, a gradual loss of kidney function over a period of time, and about 15% of US adults seems to have this disease. But the main issue is diabetes being one of the major causes of CKD in adults in not only United States, but throughout the world. And as you can see from this pie chart of all the CKD patients, diabetes is nearly 40% of the total cause of the CKD in the United States. So, and it's also known that diabetic kidney disease is associated with a sclerotic glomerulus. There is lack of perfusion, and the kidneys become shrunken. So what can we do to treat this condition a little bit better? So over these different stages of this disease, we mainly focus on, as you heard, on blood pressure management, blood sugar management, cholesterol management, and control of the protein in urine. But as you know, most of these therapies seem to not control the disease adequately, and the disease keeps on progressing because diabetes, even with the best of the treatment, often progresses. And ultimately, it can lead to a situation of dialysis and transplant. So what else is there to help our patients with diabetes and vascular diseases? Is there anything from the regenerative medicine that we can utilize here? So we have pancreas and kidney transplant, which has been fairly successful. And the other option may be a stem cell therapy. Now, I'm not going to go into embryonic stem cells and pluripotent stem cells. I'm going to talk about very simple adult stem cell therapy. And there are two of them that has been come up. It is mesenchymal stromal cells and endothelial progenitor cells. And I'm going to introduce these two concepts a little bit over this period of time. So, as many of you may know, the bone marrow is the mother of all stem cells. And essentially, what we call the endothelial progenitor cells, which is more clearly defined as the cell surface marker, would look like very much like a white blood cell, which is on the top of the diagram here. And it's mostly produced by the bone marrow matrices and comes out from the marrow to the periphery to repair and regenerate the tissue. The chronic stem cells are evident in almost every organ in our body, kidneys, and also, of course, liver and others. And they look more spindle-shaped muscle-like cells called the mesenchymal stromal cells. To going back to the endothelial progenitor cells, these, as the name suggests, that these have something to do with repairing the endothelium, either directly or by simply the growth factors that it produces. And it's very well known that the stem cells or the baby-like cells seems to have more growth factor potential than a mature cell. So as you can see, these would look like a circular blood-like cells. And over a period of time, they would come together to start forming an organelle, which we'll call a colony formation unit. And these subsequently on culture, and I'll show you a picture later on, can lead to a capillary or vessel formation. So our goal in this small study that I'm about to talk about was to see a comparative stem cell therapy, not only with mesenchymal stromal cells, but endothelial progenitor cells, and if we can augment and as an adjuvant therapy to the CKD treatment. And the stem cells can come from the same person, from their blood, or any other tissue for the mesenchymal stromal cells. So it's not a very far-fetched idea at this point. So endothelial progenitor cells has been used for decades, almost 2 decades now, in cardiovascular field. It's very interesting that it hasn't come to other vascular paths like diabetic kidney disease. And here we are describing a study in a rodent heart where the main vessel to the heart has been tied off, and then we looked at what happens to the heart and the ventricles. And you can see on the left-hand side with saline treatment and with endothelial progenitor cell treatment on the right side, there's a clear difference in the left ventricle and its muscle retention with the cell therapy. And this goes on to the fact that there has been multiple human trials using these cells in cardiovascular field, not only in chronic angina, but even in myocardial infarction. But the problem comes when there is a diabetes. The issue is all the studies that I showed you in the human trials were not on diabetes patients. They were mostly in chronic ischemic patients. When it comes to diabetes, it seems these are the human trials that has been done. As you can see with diabetes, it seems to favor the control with cell therapy or progenitor cell therapy. Why is that? That may be because diabetes is a chronic inflammatory condition with pro-apoptosis. So cell therapy, going back to an inflamed scenario, may not always help. So you might need to tweak it to a certain extent to adjust the onslaught or the disease process that is going on so that it doesn't succumb to it. So we looked at it, and from the humans, so-called CD34 cells, which are a progenitor mark, and showed that these cells actually start dying within 24 to 48 hours if you change the media from normal glucose to high glucose. And these are the two markers, and this is a flow cytometric analysis. We looked at the gene expressions, and it wasn't a shock that the genes that are upregulated are P53 and P21, and any scientist or anybody who has been looking at the scientific journals would know that the P53 is a master cell death regulator, and it upregulates to kill a cell. And diabetes, or exposed to diabetes milieu, has these genes upregulated, as well as inflammatory genes. So we tried to see if we can somehow take these cells, which has been used in cardiovascular field for a long period of time, but try to make those cells so that they don't die in a diabetic milieu. So we essentially developed a mouse model and also looked at the human cells where we simply knocked out the gene in a mouse model and looked at what happens in hyperglycemia and high glucose. And when I say hyperglycemia, I'm talking about 20 millimoles of glucose, which is 360 milligram%. Now, a lot of my diabetes patients this afternoon or this morning would walk in with that number. So it's not an astronomical number that we are testing here. So you can see on the left-hand side, cells in high glucose rounded up, dying. If you have a knockout, they don't and survive fairly well in hyperglycemia. Not only that, you can actually progress to a perfectly endothelial-like morphology over a period of time. And not only that, you can actually make them into a capillary-like in a matrigel. So it seems that only knocking out one gene that kills these cells can actually make an endothelium in a dish. And this is true for mouse, and mouse it's much more difficult than humans. And there is no mouse endothelial cell that you can buy. And that's why we patented this process of mouse endothelial cell culture. So, but as you can very well imagine, you don't really want to silence or knock out a gene which is so crucial for cell death and cell regeneration for a long period of time. So we devised a system so that you can only need to silence it for a month. And we have those tools with various viruses like cold virus, which stays in you for only a month, and then you would get rid of it. So we use that technique to silence it for a short period of time and show that if you transfer it in a diabetic vasculopathy like PVD, it actually does improve, and this has already been published. So we wanted to test this in a diabetic kidney disease. So as you can see, the diabetic kidney disease has shrunken vessels and an ongoing vasculopathy, and to see whether the two modalities that has been used again and again, mesenchymal stromal cells, endothelial progenitor cells, and an endothelial progenitor cell where this critical gene has been silenced only for a month. And let's see which works out the best. And as I was telling you, this mesenchymal stem cell therapy in diabetic kidney disease has been tried in a number of publications, as you can see. In the last 3 years, there were 21 publications on it, but only one on endothelial-like cell or even blood-derived cells, which is amazing because it's exactly the opposite in cardiovascular field. So anyway, so we went on to look at why mesenchymal stromal cells may not be such a great idea, because in kidneys, when the disease process do happen, there is a mesenchymal transformation from the epithelial structures. So if you are putting in mesenchymal stromal cells, you are actually can augment a milieu post-transplant, which can actually push the epithelial cells in the kidney towards mesenchymal tissue. And so why don't we try cells that can and has been shown in cardiovascular field to augment vasculature. So we looked at these 3 transplants under the kidney capsule, and we showed that the red bar is our treatment, the blue bar is unmodified cells, and green bar is the mesenchymal stromal cells. And as you can see, proteinuria, protein versus creatinine ratio, seems to favor the best in the P53 model. And this has been looked at multiple animal models. If you look at the ultrasound of the kidney, looking at perfusion, and again you can see mean blood velocity in both mean and peak using a ultrasound device showed better flow with the P53 cells. This is while the blood pressure did not change significantly, because if your blood pressure goes up and your flow goes up, that may not be a great thing. But your systemic blood pressure, both systolic and diastolic, did not change significantly across the group. Heart rate, on the other hand, actually went up in the mesenchymal stem cell therapy, which may not be such a great idea. If you look at, there was another method of looking at blood flow, which is called laser Doppler. Again, here, it seems the P53 silent cells or transient silencing cells might actually help. Gene expression shows the same results, and this is a histology. And if there's any histologists in the room, you would hopefully appreciate the one figured in the middle looks the closest to the normal kidneys histology. You can actually see the retention of glomerulus in that figure. So what I've told you until now is that stem cell therapy, hopefully, can be a adjuvant therapy to our current treatments, along with dialysis or others. Even if we can improve the GFR to a small extent, I think this is still a safe therapy. Taking all our outcome measures, we believe that the p53 silenced EPC therapy seems to be more beneficial than the mesenchymal stromal cells. And also mesenchymal stromal cell therapy also needs to be investigated more than what it has been now. So in conclusion, cell therapy and maybe even in the future, cell-derived therapy like exosomal therapy, cell-free therapy, may be also an opportunity to look into in diabetic kidney disease. I just believe that this diabetic kidney disease cell therapy or cell-free therapy has not been investigated as it has been in any other vasculopathic diseases. So is the cell therapy a holy grail for kidney disease? I don't know, but there is a possibility and needs to be investigated more. So there is some progress, but as you know, it's a continuous process. This is my team in GW, and these are my acknowledgements. I would particularly like to acknowledge Pedro Jose in GW, who has been very helpful, and Dr. Raj for their contribution to this process. Thank you.
Well, let me first start by thanking Dr. Bakris, Dr. Sloan, and Dr. Sain for a very insightful and a very relevant presentation. Before I open the floor for questions, I just had a quick comment on Dr. Bakris. I mean, as a relatively new hypertension person who is seeing more and more number of hypertensive patients in my clinic, I think these are exciting times because we've gotten rid of a very complicated classification of hypertension. We have incorporated more of an evidence-based approach to treating hypertension. And I feel a little more empowered when I tell my patients that I have a target for you. So along those lines, my first question to Dr. Bakris is, after I believe GNC7 clearly identified the increased cardiovascular risk with systolic of more than 115 and the diastolic more than 75. But I didn't see anything along the lines of intervention. How aggressive should we lower the bar? How aggressive should we be in not only identifying, but in treating someone who we know has a clearly elevated cardiovascular risk?
So that's because the bar is movable, just like biology is variable. Everybody wants to apply physics to medicine, and it's a problem because we don't live by laws, we live by variability. And the key to biology is to reduce variability. The famous Sarah Lewington data from Lancet that you're quoting there at 115/75, if you carefully look at that, your cardiovascular risk at 115/75 at age 80 is 17 or 18 times more than it is when you're age 30. So that's something you can't fix. So I think the important point is that, at least when I approach this, number one, it's what's the patient going to tolerate, and the stiffer the vessels they have, the less they're going to tolerate, meaning if they're coming in at 180/70, you're never going to get them to 130. You will, but they'll be sleeping all day. So it's a question of what are they going to be able to tolerate. Clearly, the higher your risk, the lower the goal should be, meaning to achieve 130. But if you're at 132, does that mean you're going to die tomorrow? Or if you're at 128, you're going to live an extra 2 days? No, it's a range. And so I think we need to think about ranges. I actually put that forth in the ADA guidelines for last year, and people liked the idea, but they hated the idea if we put it out to the masses, because then they're going to say, well, what are you talking about? So I think for a physician and for a patient, the 130 is kind of a median, I'd say. And if you're at 125, that's good. It's not better, it's good. If you're at 115 or 110, I'd say if you have diabetes, that's probably bad, and you need to be higher, because that 115 is in the general population, and it's epidemiologic data. It doesn't take into account kidney disease, doesn't take into account diabetes, doesn't take into account coronary disease. It's, if you're just generally healthy. So I think you have to modify those numbers in ranges based on what the patient brings you as physiology. So that's how I'd answer that.
Thank you. As we wait for anyone from the audience, I also have a tag-along question with hypertension. Now, there's a huge push for home-based monitoring of blood pressure. Every algorithm and guidelines you look at, they talk about ambulatory blood pressure. But the uphill battle for me has been to get the insurance company to pay for $35 of a blood pressure cuff, or the outrageous amount of out-of-pocket costs for the ambulatory blood pressure.
So I'm going to give you a little secret that I'll share. And I realize this is being filmed, so I'm now going to get castrated when I share this with you. But there's a website called AmronHealth.com. That's Amron Healthcare. Amron Healthcare, all one word, .com. If you go there, you'll find their monitors, and everything is discounted. And then if you put a little magic word in there, doctor, you get an additional $30 off. So you can buy a $100 monitor for $30, ultimately. So certain insurance companies will pay for things, depending on your plan, but most won't. And if they do, they're only going to cover it for up to $25 anyway. So it's something is better than nothing. But at all cost, I would say everybody should be measuring their blood pressure at home, not every day. But once you get stabilized, the recommendation for maintaining things is once a week. And measure it in the morning, because that's when you're most likely to die, because of data that we know about from the 80s. So that surge in the morning from 4 a.m. to about 10 a.m. is when you're more likely to have a stroke or an MI. So that's when pressures tend to be higher, believe it or not.
No problem.
Thank you.
Yep.
Do we have a question from the audience? No. All right.
I think we're out of time for this morning, but thanks, Dr. Sharma. Thank Dr. Bakris and Dr. Sloan and Dr. Sen for that presentation. So this concludes the morning part of the session today.